Hello and welcome everybody. I can see the numbers just clicking up there as people are joining. Welcome to our RCGP webinar. Tonight it is quality improvement tools, and the title that we've given it is making it easy to do the right thing. So welcome on this wet evening. Well, it's wet here in Scotland. I'm just going to introduce myself. My name is Sarah Luty. I am currently in the west of Scotland. I work as a GP and an educational supervisor, and I am working for the RCGP in this project called the Quick Project, looking at capacity and knowledge in primary care. I also work within quality improvement at NHS Education for Scotland, and I'm really delighted to welcome you all tonight as part of a series of webinars as part of this Quick project. In total, there's 6, and they are this is the second one. We might talk a little bit about stuff that was discussed at our last webinar last month, but that is available on the RCGP YouTube channel. And as we're all coming in and getting settled into this webinar, I'm going to ask you to get your phones out and log on to menti.com. And this is the code that's up there, and that will help us make the session a little bit more interactive as we go through tonight. So thank you for doing that. As I said, this is a series of webinars. The next one is planned for the 1st of December and more after Christmas after that. So I'm going to introduce you to our host of this evening, or our speaker of this evening, who is a colleague of mine in NHS Education for Scotland and an expert in our subject matter because he has designed and developed training. He's smiling at me with surprise at that. He's developed training for GP trainees. He's written e-learning modules on quality improvement for educational supervisors, and he is doing a PhD as well in this subject. So without further ado, I'm going to introduce you to Duncan McNabb, who is going to be our host of the evening.
That's brilliant. Thank you very much, Sarah. And it's quite strange for you to actually be nice to me like that. So that's a bit of a surprise. So thank you very much for having me here, and welcome everybody to this webinar. As Sarah said, I'm Duncan McNabb. I'm a GP in a practice in Irvine, which is about half an hour south of Glasgow. And I have a role in NES, so NHS Education for Scotland, where I'm one of the GP assistant directors, and I work in patient safety and quality improvement. So today, as Sarah said, we're going to be talking a bit about QI tools, how they can help you do the right thing as you work your way through a QI project. Now, I've kind of stolen these slides a wee bit, or Sarah stole them for me, because Heather used these in the last webinar, and I thought, well, that's a fantastic idea. And what she was saying is, your QI journey is a bit like your journey with your patient. You meet your patient, you get your history, your investigations, you have goals for the treatment, you then make the change, you implement the treatment plan, and then you assess how things go. And that's a bit like your improvement journey. So you have to identify the problem, then you investigate what the problem is, and only then do you then start thinking, okay, what are our aims here? What are we going to change? And to me, there's great parallels between these. But what we find, and at NES, Sarah and I work together at NES, and we look at probably 300 quality improvement projects a year, and we find areas where commonly there's problems at different parts of this journey. And one of them that we'll talk about later on is that people often jump into the changes in quality improvement. So they jump into the changes before they really understand the problem. And that's a bit like jumping into treating your patient when you've not done the history or taken the bloods or whatever else you want to do. And so for your journey in quality improvement, there's different things and different tips and different tools that you can use at different stages that will help you to implement successful and sustainable change. So we're going to be talking today about this quality improvement journey. So this starts with creating the conditions for change, understanding the current system, then developing your aims and testing your changes and implementing them, and then finally spreading out. So we're going to be talking about how you work through that journey and the things we can do to help you along that way. So we're going to try and use Mentimeter, okay, which is just a way of getting some ideas from you guys. It's difficult to be interactive when we're doing it like this and we're not in the same room, but we just want to get a few ideas that will hopefully refer to as we go through. Now, I think it's actually supposed to be www.menti.com. I changed all the other slides, but must have forgotten this one. And if you go there and enter this code, then we'll be able to ask you a few wee questions. Okay. So this is where I now need to do the difficult stuff and switch between screens. So what we want you to do is type in what quality improvement tools and methods you currently use. So we just want to get a wee idea of the sort of things that you're using. And if you type them into Mentimeter, into Menti, we'll get a few things coming up. Great. So this is exactly the sort of stuff we're thinking. None yet. I like that. That's good positive thinking, you know. Yeah. So we've got audits, process mapping, PDSA cycles, fishbones, SEA, yep. Stu, well, we're getting some interesting ones as well, yep. Brilliant. And some who are saying none and none yet. So that's what this evening's about, to try and introduce you to some of these and see if you think they would be useful. Okay. So I'm just going to pause it there. Okay. Okay. And I'm going to move on to the next one. Okay, so what we'd just like to see is what sort of projects are you working on currently? What are the topics for that? Is it related to prescribing or different things? What sort of things are you working on at the moment, and or are you planning to work on in the future? You just one word or two words, just to see what your thoughts are. HRP.
This is where we get ideas, really, isn't it?
That's the only reason I do this. It's to steal ideas for when I go back to the practice. So we'll get HR, and I make notes of these so that I can refer back to them.
Cancer referrals.
Anticipatory care plans and prescribing, yeah, frailty. There's one after your own heart. Sarah, you're doing a lot of work on that. Menorrhagia. Okay, brilliant. Okay. Pre-diabetes, yeah, so that's quite a good one as well, isn't it? A lot of stuff you can do there. Health inequalities, again, we had a meeting about QI and that today as well. Fantastic. Okay, I'm going to shut it down, close the voting in just a wee second, okay?
Workload, so we could get the outcome of that. That would be
solve all our problems.
Solve all our problems.
Brilliant. Okay, so I'm going to pause that and go back. So there's some really interesting projects there. Okay, and so we'll maybe try and pick up on some of them as we work through. Sarah, you can jump in and see what you think there as well. Okay. But we're going to start off just by talking about, well, what do we mean by quality improvement? It can appear very different, you know, if in a big national quality improvement project or one in a large federation of practices or secondary care, you know, it could look a bit like the F1 team, or it could look like, you know, the go-kart here if it was just a much smaller project done in a much smaller practice. But the thing is that they all follow the same process, they follow the same journey, they use the same methods, the same tools can help. Obviously, there's different contexts, there's different resource for these different areas that can make it different. But they all, they all measure something like lap times, they all reflect and evaluate what they're actually doing based on results and leading to improvement. And we're just going to talk you through some of the different things that you can be used. There's different definitions of quality improvement, and this is one that I quite like. And what it's saying here is using a specific method to reflect and evaluate what you're doing, leading to change. And so when we went back to what you'd put in the mentimeter about the things you'd used, audit, yep, absolutely. It's a form of quality improvement. It's a specific method, helps you reflect and evaluate what you're doing. It leads to change. SEA, significant event analysis, again, it's a method, helps you reflect and evaluate, and it leads to change. So there's lots of different quality improvement methods that you can use. What we're going to do this evening is focus probably more on the tools around that can actually be used with lots of different methods, but we're going to use the model for improvement as kind of our main method that we're talking about. And we're going to work our way through talking about the different bits of the QI journey. And as we go through, we'll talk about all these different types of tools. So some people have mentioned some of these already, and we're going to probably focus on the areas that we've noticed from all the projects we review where people seem to struggle, okay? And as I said, we're going to use the model for improvement. So a lot of you will be very familiar with this. I'm sure there's some experts in the audience here with using this, maybe others less so. But the model of improvement is really in two parts. The first part is like the thinking bit, really. It's, it's three questions. What are we trying to accomplish? So what's our aim? How will we know a change is an improvement? So what are we going to measure? And what change can we make that will result in improvement? So again, about changes. And the thing about the model for improvement is it encourages us to think about this, the PDSA cycles, plan, do, study, act cycles. And that's the doing bit. Now in GP, certainly up here in Scotland, we're very used to doing audit. It's kind of our bread and butter. All the trainees do it. We often do it for appraisal. And there's a lot of similarities between the model for improvement and audit. They both set goals. An audit is they define criteria and standards. They often then implement change. They have a measure before and a measure after change. So there's a lot of similarities there. There's a few differences as well, really, and some are semantic. So the audit define criteria and standards, whereas in model for improvement, you have a name statement, which can be quite similar. Audit's quite often a before and after data collection, certainly with an 8-point criterion audit. It's usually a before and after with one change. Whereas the thing about model for improvement is it's about multiple small tests of change, testing things out, seeing if they work, if not ditching them, if they do work, continuing with them. Audit's often only numerical data, and often, certainly my experience of audit was often blooming massive data collections, looking everybody on amlodipine and simvastatin and all these different things. And the model for improvement, you want some quantitative data to see if people have improved, but you can also use qualitative data, get verbal feedback from people even just to see how changes have landed. And the other thing about the model for improvement is associated with these tools. They're not definite that you need to, you couldn't use them in audit, but they are often associated with using the model for improvement. So back to model for improvement and starting with the first part there, which is about creating conditions for change. This is one area where we see big problems. So it's about building well, getting people involved. And what we find is people do fantastic projects that have spent absolutely hours on, and they've just not had buy-in. And so a lot of that work's been wasted. And so we spend quite a lot of time when we're doing training is getting people to think about how they get everybody involved. And, there's a few tools that we're going to talk through here, obviously, because that's what the subject tonight is. You don't need to use these tools, but they do give you a few examples of things you can use. The first thing I think when you're doing this is you need to be able to answer things. You need your elevator pitch. When you're talking to someone, how are you going to sell them your project? And you've got to think of a few different things. So, what's the problem? Why are we trying to change? What are we trying to change? Is it because guidance has changed? Or the thing I really like is thinking about everyday work hassles. Sometimes quality improvement makes my life harder. And I think it should also try and make my life easier. So when you're picking a topic, thinking about, okay, what are the hassles in my work? How can I try and improve them? And how can I improve them for me, for my staff, and for my patients? And so I think that's important. So how do you know these are problems? Well, two ways to think of this. You can have stories and you can have numbers. Now, a lot of people love stories, okay? And patient stories, staff stories of things that have gone wrong or things we could do better often helps to win people over. But there are a certain subset of people who like numbers. And so it's quite often good to have a bit of baseline data and some numbers to show people and try and win people over as well. You've got to think, oh, how do things work just now? If I implement this, who's going to be affected? Is it a priority? Can I do it in a timescale? Is that realistic? And having these before you start pitching your ideas to your partners or whoever else in the practice, I think is really useful to understand. So the first QI tool we're going to talk about here is a simple thing called a prioritization matrix, which is, I have to apologize if you hear noise in the background. I've got a child doing a cornet lesson who's decided to move upstairs to do it. The prioritization matrix is a very simple thing, and it's really useful if you've got lots of ideas. So I use this in the practice if we've got lots of people who've got different ideas of what they want to do or how they want to do it. And we've used it in our cluster, thinking of different ways that, different projects that we might all want to do. So several practices working together. And it's simply thinking about the effort involved versus the potential impact. So if, for example, we wanted to look at all our prescriptions and make sure that they were linked to a read code, you might say, well, that's a huge amount of effort, not sure the impact of that. If you said, okay, well, we've only got 10 patients in methotrexate, but we don't have a robust monitoring system, you might say, okay, well, that's not a lot of effort to implement, but potentially could have a large impact. So it's a simple thing, again, that you can use with your team to try and decide these sorts of things to help build that will to start a project. Should have warned you at the beginning, a lot of these things have daft names, okay? So people who work in QI like to give things daft names. It keeps us interested. And the next one's called a force field analysis, okay? And again, something I use all the time in the practice. So you write the problem in the middle. So you do this on a whiteboard, do it over coffee, and then you think, and you get everybody to come up with what are the forces for change and what are the forces resisting change. And I find it's really good because it gets that grumpy GP in the corner to actually tell you what they think right at the start, rather than after several months' work when they say, oh, this is rubbish, not interested, don't buy into it. So that's where I use this quite a lot, to get people's opinions out in the open early on. And so if we were thinking of changing our annual asthma reviews to doing them remotely via video consulting, you might use this at a practice meeting to say, okay, well, what are the forces for change and what are the forces against? They might come up with things like this. So forces for would be reduced footfall, and it would increase access to patients who are working. I'm not sure about you, but when we invite people, for asthma reviews, I would get very low turnout. So this might help them to involve them. But the forces resisting change might be, well, people don't really believe it's safe. There might be an inequality of access, that some people will not be able to get access. And other people will say, well, I don't think it'll save any time. I'm not interested in this at all. And so when you get all these things out in the open, it can decide for you if you want to go ahead with this, but it can also direct what you're going to look at and what you're going to measure. So if you say, well, it doesn't save time, say, well, okay, well, we'll measure it and see. And because we're doing this as small tests of change, We can test this with just 1 or 2 people. We can time it. We can see how long it takes. We can look to see if it was safe. We can get feedback, and we test it out rather than implementing a huge big change all in one go. So you can do this. You can then draw arrows around them to show how important they are. You can score them out of 5 if you think, if you so wish, to just try and get a shared mental model in your team of why you're doing this project. And it's a great way to get people bought into this right at the start. You've also got to think how you involve everybody in the practice. And some people need to be involved more than others. It's usually good to get a wee improvement team together. For your asthma reviews, you'd maybe want a GP, a nurse, admin representative there. And you've got to think, okay, well, how much do people need to know? And you can think of this, of how much it impacts on their work and how much influence they would have on the project being successful. So again, if we use the asthma project, if we're talking about practice nurses, it would have a huge impact on the way they work, and they would have a huge level of influence if it succeeded. So they've got to be managed very closely. The admin people, yeah, it'll have a large impact on how they work. Will it have a large impact on influence on whether it's successful? Maybe, maybe not. If not, then they're probably in the keep informed box. The practice manager might be more in the keep satisfied box, not a huge impact on their work, but a large level of influence. And so sometimes useful to think of that when you're thinking of how you keep people involved. So I've spent a bit of time in that, and I think that part there, creating the conditions, is really essential and often missed out in projects. The second step is about understanding systems. You can't change something unless you understand how it already works. So there's a couple of things, and people have mentioned them already, which is brilliant, okay? So process mapping. So process mapping, a simple thing, you get your team involved. You can do it with Post-it notes, or you can do it in different ways to just think, what are the steps involved in this process, and mapping them out. Now, Sarah's got a brilliant story about her. She looked at her prescribing system and she thought she had it all mapped out, and then spoke to her staff and said, oh no, what about the mat? And she went, the mat? And she said, yeah, the mat. What about the mat? I said, what do you mean? Well, apparently when the surgery was shut, people used to shove slips under the door, and some of them would go under the doormat. And so for their prescribing system, they had to look and say, well, got to check the mat. So that was one of the steps that was essential right at the start. But the idea with this is that it's a joint thing. Your team does it, so they've got a shared understanding of the system. If you look at the one here, this is about a practice did, looking at how they managed their liver function tests. So they came in, they checked them, repeated them potentially, then did a liver screen, ultrasound, and potentially coded them. And then when they discussed it all, they found that there was huge variability in the time frame for people repeating them, what they did in a liver screen, and how they coded it. And so these were their targets for quality improvement and things they wanted, the changes they wanted to test. The next one, again, silly name, but a fishbone diagram, or a cause and effect diagram. So the head of the fish is what you're not doing, the problem you're trying to solve. And then you start thinking of, okay, well, what are the reasons that we're not doing that? And, again, if we looked at our asthma reviews, you might come up with these. So lack of awareness for staff, they liked it the old way, don't know how to do it. There's no protocol. We've only got rooms with video, 2 rooms with video. Patients won't like it, these sort of things. And again, from that, you can come up, okay, well, there's no protocol. Well, let's write a protocol and test it. There's a lack of awareness. We'll do an educational session and see how that works. They don't know how to do it. Okay, well, let's work through, do one patient and just show people how to do it. And then, okay, well, maybe we need to do a patient information leaflet, test it with a few patients, see how it works. Survey the patients and see if they liked it, and get more video. So again, it can come up with a number of things that you might want to change. And you can bring all these different things in to develop a plan of all the different things. So if you had a massive project, you could maybe look at all of these things. Or you might split it up and people could do one bit or the other bit. But that's trying to understand both the system and the problem before you implement change. So again, like our patient journey, we're working our way through here of trying to understand what the problem is before we try to treat it. The next bit's about aim statements, okay, and what are aims and what are we going to measure, okay. And it's probably easy just, you know, I've seen other acronyms for this as well, but we tend, when we teach it, we just tend to stick with, you know, making these SMART, so specific, measurable, achievable, relevant, and some sort of time limit on them. And my favorite way to do it is do blankety blank, which is back on the tellies these days. So even the younger folk will hopefully know about it, but, you know, get them to fill in the blanks to reduce or increase something by a certain amount by a specific date. And that something is specific, measurable, and relevant. The certain amount is achievable, and by the specific date gives you your time limited step. But that's quite similar to what we did in audit. What's maybe slightly different, or certainly to how most people do audit, is actually thinking of different measures. So you can think of your outcome measure, okay, so you can think of what the outcome of the project, but you can also think of process measures. So these are things that must happen to achieve your desired outcome. So if we talked about our remote asthma reviews, you might be thinking of the percentage that are delivered remotely. But the process measures might be, okay, well, how many people were invited, how many people attended, these kind of things. And the balancing measures, I think, is key. It's thinking about unexpected effects or effects elsewhere. So if we said about that grumpy GP saying he doesn't think the remote asthma reviews are safe, well, or would save time, these balancing measures are things that you can measure as you go along to show that these things are okay. So the next bit is moving on to testing changes. So what we said often in audit was that we'd often do one big change. It doesn't need to be that way. You can do loads of cycles of audit as well. But often it was that, you know, you would design and design and design, and then a week on Tuesday, bang, you're going to launch and implement. You'd spend ages getting this protocol, your new protocol, and all this absolutely perfect. Whereas the model for improvement and PDSA cycles thinks, okay, well, let's try it out, just test it, do a bit of design, test it out, see if it works. If not, change it, test it, change it, test it, and just iteratively adapt and change. Now, being honest, this is how a lot of us would have done audit before anyway. And if it wasn't working at coffee, we would change it. And if it wasn't working at lunchtime, we would often change it again. So it does fit, I think, quite nicely with the kind of GP approach to these kind of things. So if we go through PDSA cycles, the P part stands for plan. So setting objectives, making predictions of what's going to happen. Then doing it, so carrying it out and recording what happens. Studying, so analyzing it and comparing it to what you thought would happen. And then acting, so what needs to be changed. Can it be scaled up? Can it be spread? Shall we ditch it and try something different? So these are the PDSA cycles. Now, what we find when we look at people doing this is often there's two areas probably where there's problems. One is in actually the planning and planning, you know, what's going to happen. But the main one's probably in the study, you know, of actually thinking, okay, well, did it actually achieve its goals? Was it what we wanted to happen? And these are areas where, you know, we spend quite a bit of time when we're doing training on this, as really thinking about how you study what's happened and then you act based on that. So the next bit as a wee example here, just again thinking about doing remote asthma reviews. So the plan might be that we'll arrange for 3 patients to have their remote asthma review done, their asthma review done remotely, and we predict it'll be quick, be safe, and everyone will love it. So we do it. We do 3 consultations. We survey the staff. We survey the patients. We review the notes to see if everything was covered, and we time it to see how long it took. And then we study it and go, oh my God, it was awful. It took much longer. The IT was awful. Everybody hated it, but it did cover all the information. So we act and we say, okay, we'll get a member of staff to set it up in advance and check the connections, and then we'll try again. And this wee cyclical test of change is a really good way of implementing and testing and then implementing change. So you can think of it in other ideas, other examples. So if you think sending photos with dermatology referrals, for example, you might say you want to increase that, but some GPs in your practice maybe are not really wanting to do that. So you could test it with one GP who's an enthusiast, get rid of all the niggles just testing it with them before you then spread it on to other GPs and get them involved. You could do it with templates for HRT management. So there was an HRT thing in the chat earlier. You could develop a new template, electronic template that automatically opens when you type in HRT review. You could test that out with one nurse or whoever's doing the review and see if it covers all the topics, if it suits them, if it works well. You could get some verbal feedback from them before you adapt and change it and spread it to other people. So it works well. It does suit a GP setting where we're very used to making changes very quickly. But the question is, I guess, is what changes can you make as well? And so we've talked a bit about ways of finding things to change. So we've talked about the process mapping involving the team and the fishbone diagram, again, involving the team in identifying things that you might want to change. The key with all these things is involving people. The topic tonight was making it easy to do the right thing. So we're talking about that as making it easy to do the right thing in quality improvement. But equally, when you make changes, you want to think about making it easy for people to do the right thing at their work. So the changes you make should be about getting rid of the hassles, making it easy to do that. People will change and continue, and change will be sustainable if people do, if the system becomes more straightforward, simplified, standardized. And it's often good to think about that and how when you're thinking about the changes you can make. And it involves getting multiple perspectives. It involves you've got to involve everybody, different perspectives on how the system works to ensure that these changes really are sort of co-designed with everybody. And you've got to understand why people work the way that they do, thinking of the demands and the capacity they have to do the jobs, thinking about the resources they have, the constraints, how things like flow of work affect them. And variability is an interesting thing. So we talked about simplification and standardization has been really useful, but sometimes people do need to vary how they work, and how do people learn from that as well. So it is about involving everybody in designing the changes. You can't do an effective QI project sitting in your room without involving everybody. Excuse me a wee sec. Another thing to think about is the effectiveness of the changes that you implement. So this is quite an interesting thing. It's called the hierarchy of intervention effectiveness, and it looks at different interventions starting at the bottom, which are things like education and training, rules and policies, double checks, moving up to what we call more system-based changes, so simplification and standardization, automation, and forcing functions. And we are a bit limited in GP with how we're able to change things like our IT systems. But just to talk you through a few of these, so education and training might be okay. You have a clinical meeting and you discuss the risks of long-term nitrofurantoin and UTI prophylaxis. And you think, oh, that's brilliant. Everybody now knows about that, so everybody will do things properly now. But that education and training won't last unless there's other things to reinforce it, and system-based changes to help people to do that. Rules and policies, so saying you've got a policy to review antidepressants at a specific time. So again, telling people what to do, sending an email, this is a new policy. Again, people will do it for a day or two and then revert back to what they were doing before. reminders, checklist, double check. So a checklist for the doctor's bag, yep, that's really good intervention. And sometimes checklists are one of the best interventions we're able to have in primary care. But again, it often relies on a person remembering to do the check. So, you know, for our doctor's bag, they're checked by one of our nursing team, and you think, well, actually, do we have time scheduled set aside for them to do it, or do they have to just find a bit of 5 minutes here or there to do it? You know, how is that not just dependent on somebody remembering? How do you make it part of everyday work, part of the system? You can, another step up from that is about simplification, standardization. So an example of that would be just in case medication, you know, for palliative patients, you're able to standardize that. In our systems, if we type in just, it comes up, I don't know, it'll not be the same everywhere, but it comes up with pre-populated things for what you can have as just in case meds, and it allows you to it makes it much simpler and standardizes what you do. So it's a really good intervention. Automation, computerization, that's quite difficult for us, isn't it, in GP to be able to change our IT systems and things like that. I suppose an example would be referral systems that import all the patient data. It means you don't need to type in their date of birth and their name and things like they would have done, you know, when I started GP. But other things are probably slightly more difficult sometimes to change there. At top of this pile here is what's called forcing functions. Again, can be quite difficult to have effective forcing functions in general practice. I suppose one that kind of almost fits the bill is in our HRT template. You're not able to shut it down until or click it as OK until you've checked the HRT preparation and that they're not an unopposed estrogen. It's not exactly a forcing function because there's ways around it, but it's kind of the closest I could come to thinking of that. So this is quite an interesting model to think of what we do. So education and training is at the bottom. Sometimes that's all we're able to do. Sometimes all we can do is that. And even when we're doing these other things, you know, if we're doing it by adapting HRT or changing how we manage HRT, you would still need those bottom levels there as well, the education and training to support these changes. But it's worth considering. And the final stage in this is about spread and how how changes can be spread throughout the practice to other practices. And this is probably the most difficult step, and I'm not sure anybody's really cracked this. Going back to the go-kart analogy, you know, are you spreading it just to have more, to spread exactly what you're doing to other places? Are you trying to continue to improve? You know, it is about how do you share these things? We've certainly not cracked it in Scotland with the worker cluster, so groups of GP practices working together. It's something that we're working on, is how they can share ideas and share things and spread the good work that they're doing across other clusters. And I know a lot of work's been done with that in other areas as well. But yeah, it's a very difficult thing, the spread and of successful QI projects. Some resources that are useful. I don't know, Sarah, have you shared this booklet before about?
No, just a link to it like this in previous webinars, but no, it's freely available if on the link.
So it's certainly something that, and what that does, I know we've rushed through quite a number of different tools tonight, and what this booklet has is a description of each of the tools and then a worked GP example, just to show you how you could potentially use it within your quality improvement projects. Obviously, the RCGP have got lots of different resources as well that are really useful and worth looking up, and as have the Health Foundation as well. Okay, Sarah, are there questions or any things in there you want to go over?
No, if there's any questions, people are welcome to put it into that question and answers box at the bottom. But I think of all of the tools that we've gone through there, I think the ones that I probably use the most would be force field diagram. I think that's probably the one. I'm thinking about the projects that we talked about in Menti at the beginning, the things like pre-diabetes. Would I get buy-in from a team? Using a force field, I think right now, in practice and the pressures that we've got and the time that we've got, I think it would be great to just see what people thought. If you could get buy-in from the team. And the other one I probably use is a fishbone. I use that surprisingly in most projects, and even without doing QI. But why is this not working? Helping me to understand why things in the practice are not working. So that was great to have a quick run through of all of those tools. I think really useful. Can't see that there's any questions, but there was a few came through as we were going through just about recording sessions and access to resources and things. I can't use the chat box to share the links to things like the stew cards, but I'll send all of that through with the evaluation for that.
Okay, and do you want me to go to the Menti slides, Sarah, then?
Yeah, we just see how people are feeling and what we're going to take home from this session.
I need to click off that, don't I, and into that.
When you get used to this mentimeter and start using the clock, I'm sure you'll be able to put music in it by the time we master it.
I don't know if I've done something wrong here, or if nobody's
maybe just thinking about it. Oh, it's just updated, I think. Just have to do. I think somebody's on the phone. Gail's just put in the chat. After this, going to have a little bit more discussion with the team, that maybe, and we see this. Gail, you're not alone with this. We see this a lot with our the projects that we do, that we review, especially I think trainees who will do so much work on their own in their room, and getting the buy-in from the team hasn't been done, and they've done a huge scroll of data, and it's a surprise that it hasn't made the impact that they expect. But actually, if they had involved the whole team from the beginning, they might have had more of a chance of that. So
yeah, or they've done a whole load of work, made a huge improvement, but when they leave the practice, it's probably going to go back the way it was before, because it was them that made the change rather than changing the process within the practice, which just because there wasn't buy-in and things like that as well. Yeah.
A question here from Helen, who is an ANP, saying, just looking for some examples of how to get started with quality improvement, and just some ideas. And if I start that off, if that's okay, Duncan. I think as an ANP, you probably have a huge amount of potential areas that you could look at. And if you're an ANP in more than one practice, even better, because you probably see what is done differently in other practices. If this is your first sort of venture into quality improvement, I would start with something very, very simple, something that annoys you, something that you'd like to change. Why is it that I'm only getting the request to do a home visit at whatever time, or the stuff that irritates you and the things that you would like to work more smoothly. Big clinical conditions, or the management of particular conditions are easier because you can apply that to a particular guideline or a particular standard. But the things that are going to make your life easier and the things that you're going to enjoy working on might be the things that just inspire you. And I don't know, Duncan, if you've got anything you want to add to that.
Yeah, I think that's key. For me, pick something, an everyday work hassle or something is really useful to pick. Or, you mentioned their guidelines and things. If you found an area where care was different from what current guidance is, again, that's another good area that you can pick. But for getting started, it's getting the ideas. There's lots of ideas. Speak to the team. It's about trying to involve the team early on as well, and they'll have other ideas of what areas are important as well, and trying to discuss them through with different members of the team. You often don't know what problems, say, the admin staff are having with so if you're thinking of examples we've seen, right, with the multidisciplinary team working, are the right people going to the right member of that team as well? And is there things you could do and work there with the admin team around that? But it's probably trying to pick something that's quite controlled and quite small to begin with, and just trying to think of, well, what can you measure, what can you change, what can and then can you measure again and see how things have improved. Everyday QI, we talk about, Sarah, things like, how urine samples are handled, how results are handled, is there ways you can improve them to make your life a bit better? Lots of different ideas of things you can do around that.
We've got another question, if that's okay. I hope that answers that. This is from Sana, that's saying that there's a wee bit disappointed about the QI training as part of GP training, because it seems to still be audit based. But how would you swap a kind of bisphosphonate holiday type audit into multiple small tests of change? And it's tricky, but
so the workplace-based assessment that has changed for GP specialty trainees, and the new stuff from the RCGP about relating to the QI project and ST1 is definitely pushing people down more the kind of model for improvement than the audit. But the problem is there's still a place for audit, so and often the prescribing things are quite useful. For me, the bisphosphonate holiday one is probably easier to do as a small test of change, because you would need some kind of educational intervention, then you would need to test it with patients, see if you need patient information leaflets that you could test with them. Is there a way to identify just a few patients and try it out with them, and get feedback, and then slowly grow it, and looking at things like how do you work out when they're supposed to have their bisphosphonate holiday? Do you have your recall systems? Are they exact enough to do that? Or so there's usually even when there's within a big audit type project like a prescribing switch, you can think of some things that you can actually just test, whether it's related to patient information, whether it's related to doing the patient reviews or things like that, and you can often just test them with people as well.
That's great. And I think there's a general movement. I think that there's definitely a place for audit, and audit's great for kind of benchmarking against standards, but those data points don't tell a story. And I think the great thing about using model for improvement is that it tells a story of the journey, and often the results will be, you know, unexpected because somebody was on holiday, or there was a changeover of staff, or there was a pandemic and we stopped doing some work that then when we pick up again we can look at it differently. So there's a real story behind that.
It's interesting, in the workshop I did earlier today in Glasgow, they were saying that the medical students are getting taught about PDSA cycles as well. And so, and what we're doing, so we're teaching ST1s, this kind of stuff, and then we're developing that in ST3 level, blending this with leadership and getting them to think of leadership through a QI lens, and then we're trying to develop that later on once they're qualified as well. And it is kind of a pathway of learning here, but I think it's fantastic that they're beginning to learn about this also in medical school as well.
Now, Duncan, I think you need to share the results of that Menti. We'll see. So let's see what sort of plan you plan more. That's brilliant, and I think if that's a take-home message, that that you're going to plan it. We do a workshop for people who are struggling with appraisal, and part of that is about urgent QI, which is where you've got to do something because there's an appraisal coming up, which is obviously no RCGP GP would be doing that, and I would never be in that situation ever, obviously. But actually, the planning, quality improvement doesn't have to be over 12 months. You can do it over a week. Think about all of the changes that we did in practice for PPE and for vaccinations, and we tried stuff, we tested it, we changed it. So the planning doesn't have to be massive, and the project doesn't have to be over a huge amount of time. So I think lots about involving team and other people's perspectives. That's great. That's great. So lots of good take-home messages here.
Yeah, it's all about the team and discussion, which I think is really good in colleague engagement. I think that's key. It's the thing I've learned more and more as I've gone on about this is, you know, everything needs to be co-designed. You can't just do things just with yourself. You can keep PDSA cycles simple. That's absolutely right. Again, some people tend to approach PDSA as if audit, as if they've got to have a big data collection to make it worthwhile. And actually, no, you know, you want to do it quick and just look with a few patients and see if it's working or not. And make sure measures include balance. Yet, I remember when I first was introduced to the term, you know, a balance measure, and thought, oh, that's just the best thing I've ever heard. So there's a good one. Any suggestions for a standard HRT template?
Yeah, I'm doing a lot of work just now with the Scottish Government and the Women's Health Strategy, which has just been published in Scotland. And I am struggling to get a menopause network of experts to agree on a standard HRT template. So that's with consultants in their field, and we're using a patient group, which is you know, something that I would 10 years ago have thought not necessary or complex, or exposing of our own feelings or difficulties. But actually having patient involvement is probably the single biggest driver of change in lots of QI that I've done. And for this menopause template, what they would like asked at their annual review is probably what is going to end up on the final template, because for them things like weight and kind of psychological symptoms are more important than other things. So
and having their blood pressure checked and smoking status recorded.
Smoking, yeah. And the other thing was that there's a slightly, the way that it's working out, it's a slightly different template for people who've had early surgical menopause than people who've had an older natural menopause. So there is, I don't think there is a standard HRT template, but when we get there, I will be happy to share it because it's a long slog at the moment.
That's the thing, you know, you can get lots of ideas from different guidance and things like that, and you can test it out and just see, do people think that this covered everything? You know, that can be a PDSA cycle. You know, you can ask the patients if they thought it covered everything, or the nurses or an expert in the field, or these sorts of things, and test it out. I've just stopped at this bit, Sarah. There's a really, really good point there. As a trainee, this is a really good point, but massively comes down to the culture and coaxing people out of their rooms. And I don't know how other people feel, but in my surgery, that's been the biggest downside of COVID, is that we're not sort of having coffee together as much and having those informal chats. But even before COVID, we had, I found out that one of my partners was doing this absolutely fantastic project on testosterone prescribing and monitoring. And then we started asking about and realized that everybody else was doing great projects that some people didn't know about. And so what we introduced was a whiteboard, the QI board, and we recorded everything, all the different QI projects that people were involved in the practice, from the real basic things, what we were monitoring, to some real kind of fancy stuff. And we used to have a huddle around that once a month only for 15 minutes, and people would give an update. And it was brilliant for the trainees because they could then pitch their idea and say, okay, well, this is what I want to do. It doesn't interfere with what you're doing, or I'm not, you know, what do people think? And it was a really good way to just kind of start the ball rolling for them as well. But yeah, it is about the culture and how you, so I think your point, Sarah, as well, as, you know, quality improvement is just something we do. You know, it should just be part of everyday work. I know at the moment it's really difficult for that, but we can use it to try and help things and make things better as well.
It's Mary is just saying that she loves the whiteboard idea, that she's going to try and introduce that. So
Yeah.
I think that's
it was great because I could take a photo of the whiteboard and include it in my appraisal and just say, this is all the stuff we're doing. So so I always like doing that.
Yeah, I think there's something about one of the appraisal conferences that we ran on QI, where the appraiser said exactly what, as you've described, that they would ask partners, oh, and that was a really good project that your partner, and they didn't know about it. And so that you're right, it's about the culture of the practice being linked to improving, and not just being about their individual projects that they need to do. So I think this trainee that has mentioned it, that could be your project. You know, you could actually run a whole QI project on that.
And if you're a trainee, then it can also be your leadership project, because you've got to do that in ST3, and that's a fantastic leadership project. So absolutely.
Yeah, and I think the culture of a huddle around the whiteboard, or it's the QI meeting, so we're bringing cake, or this is something that is a positive thing. It will change, and I think it can just make a team. I'm not going to go as far as saying joy, but it can make a team work well together. And I think that some of these tools make it happen. It makes it easy for it to happen. It gives you an excuse to get people around a whiteboard with a force field diagram, because you have got the structure to do that, to host that meeting and get those ideas out there. So yeah. Now we're just coming up towards the end, so if there's any more questions, or if there's any more of these that you want to pick out. There's one there about, I'll feel more confident making suggestions for QI. I had to chair a cluster meeting that they couldn't agree on a topic, and a couple of them had their pet projects that they wanted. So a couple of practices brought things that they wanted as a very strong idea, and just doing, okay, what are the pros, what are the cons, what's the impact of this, what's the impact, influence, what's the effort versus impact, all of those things, having the tools, having them up on a board. And I just had my back to the audience and I'm just writing. And there was energy in the room that wasn't there before because people didn't want to do group projects. And I think there is some of the projects that they put forward were absolutely fantastic. Some of them were very simple because of the stress that the practices were under. So I don't think there's any suggestion for a QI project that isn't worthy of discussion in some form. You know, we did a joke one, or to demonstrate some of these tools. We did, why do we not have a bean to coffee cup? Bean to cup coffee machine in our practice, and it was just to practice using the tools, and it brought out huge discussions about the culture of our practice and our values, and it was I enjoyed it, even though it was just a demonstration of a tool, and we got one.
I was going to say, did you get one?
That was my Christmas present from our practice. I obviously persuade them. Wee bit there about colleague engagement. Yeah, I think that's great. One more question that we might have time. What's a big one? So this is about trying to make green changes at a much higher level than practice. So at a kind of for our equivalent would be a kind of health board level of change. So at very large scale strategic level for something like green changes. So what would our top tips be for a big project at a kind of, like, for Scotland size, almost national level, and it fits with our COP26.
Yeah. I think that's about being able to influence the right people, isn't it? So it's do you have the right people that you're able to speak to and able to influence, and how are you going to influence them? So again, getting in the door and getting in to speak to them is the first problem usually, and the second thing is selling them a vision and showing them the it's your elevator pitch, if you like, probably in a lot more detail. I don't think necessarily you would work through these tools with different people, but what you can do is produce guidance for practices that can help them implement some of the changes at a local level, and as long as that's supported by national changes or larger scale changes. But yeah, I think that requires slightly different approaches probably to influence the higher up people. Yeah.
And I think breaking it into all of the multiple, a big project like that, you can work at, community pharmacy level and recycling inhalers, practice pharmacy level. It's breaking that down into what's achievable at each level, and how do you influence that. I think trying to get just GPs together on that one is probably unlikely to be successful.
Yeah, the other thing is having evidence of it working. So you could have a local example of that being really successful and spreading out to other practices, and that can often be an example for a national or a larger organization to take forward as their direction. We've done that with opiate prescribing. That's been changes there that have been spread out to other areas because of success that's been demonstrated in one or two practices.
Yeah. And I think things like the RCGP Greener Practice Toolkit is great, but you have to be bought in to the project before you're shown the toolkit. And I think this is one of the things that we do pretty poorly at that higher level, is that we implement from above without buy-in from individual teams. So, and whether or not there would be opportunities for some smaller areas to do parts of that and scale up and spread across the way.
Interesting thing is we've been getting loads of projects from trainees in Scotland about greener practice work, and
So
it's almost, you know, we're going to try and bring some of them together as well to showcase that work.
yeah. Yeah, and the hugely variable. A lot about greener prescribing, a lot about nature prescribing, some about. I mean, to be fair, the nature prescribing was from the cairngorms, which I think might be slightly easier than city centre. So now I think that's us for questions, and I think we're just slightly over time, so I'm just going to take this pause to thank Duncan for that chat. I hope it was really useful, and from those take-home messages, it sounds like it was. And I will look forward to seeing you at the next webinar, if you would like to, which is on sort of going beyond contractual QI, and then we move into QI for appraisal, and then in the new year there's a lot more about kind of population level QI. So thank you once again for your attendance, and thank you, Duncan, for that presentation. That was great.
Thanks, everybody.